Welcome and thank you for joining the first digital discussion of a two-part program featuring panelists who will provide their perspective about how the pandemic is affecting Black, Brown, and Native pregnant people. My name is Nikisha Jones and I serve as the project lead of the National Maternal Health PCOR Network, which is an initiative funded by the Patient-Centered Outcomes Research Institute, also known as PCORI, and is also housed at Health Resources in Action, a public health nonprofit based in Boston, Massachusetts. I am joined today by my HRA colleagues, Lauren Onsong and Inequity Blanding, who is helping to facilitate today's discussion, and Christine Gordon-Davis is also helping us with social media. So please feel free to use the hashtag NMHPN and Equity in Pregnancy. Lauren is going to share this information in the chat. And while you're there reviewing that information, please tell us who you are and where you're joining us from today. The network exists to collaborate across many sectors to respond to inequities and adverse outcomes in maternal health, including historic and structural racism in maternal care. Today, we have convened some of our network members to discuss what they are seeing regarding the impacts of COVID-19 in the communities their work is centered, and what we should be thinking about, supporting, and organizing our work around to protect pregnant people. And just a reminder, please enter your comments in the chat box or use the question feature to submit questions, and feel free to address your comments or questions to specific panelists. Our panelists today include Nneka Hall. She is a pregnancy and infant loss awareness advocate. She is also the founder of the QUILT campaign, and QUILT stands for Quietly United and Lost Together. Ms. Hall focuses primarily on the diversity of experiences in infant and maternal mortality. We also have Dr. Rachel Hardiman. She is an associate professor and researcher at the University of Minnesota School of Public Health. Dr. Hardiman has forged a research partnership with Roots Community Birth Center in North Minneapolis, where she focuses on reproductive health equity and improving outcomes for Black birthing people and their babies. Dr. Hardiman is an appointed member to the Minnesota Maternal Mortality Review Committee and also serves on the board of directors for the Planned Parenthood of the North Central States. We also have Ryan Eagle joining us today. He is an enrolled member of the 3 affiliated tribes of the Fort Behold Indian Reservation in North Dakota, the Mandan, Hidatsa, and Arikara Nation. Ryan is the research project manager at the American Indian Public Health Resource Center at North Dakota State University, where he provides technical assistance to tribes regarding research processes and program development. We also have Dr. Charlotte Smith, who is an assistant professor in health services and systems researcher at the Institute for Reproduction and Perinatal Research based at the University of Kansas Medical Center. Her primary research focus concerns strategies for organizing and financing public health services, infant mortality, and program and partnership development. And lastly, we have Tamoria McQueen Saba. She's a maternal health advocate, writer, and speaker, specializing in mental and physical trauma due to childbirth and pregnancy. After her own near-death birthing experience, Ms. Saba recognized a need for birthing people to have their birth experiences validated. Ms. Saba has written for several websites and is often a featured guest speaker for hospital support groups, as well as information sessions for doctors, midwives, and therapists. And before we begin, we want to acknowledge the time that these individuals are providing to us today. They took time out from their schedule to participate in today's discussion, and we feel very special and are very grateful they joined us. So we're going to get started with our first question. And Nneka, I'm going to direct this question to you first. To help our audience understand concerns of Black, Brown, and Native pregnant people, share with us the major concerns or disparities before the pandemic.
Wow. How long do I have? Thank you once again for having me. Before the pandemic, the concerns were not being heard, symptoms being overlooked, feeling as though our voices were not valid unless someone with a medical degree or in the medical field somehow said that our voices were valid. The reality is our mothers and our babies are suffering. They were suffering way before this pandemic, and they're continuing to suffer during this pandemic. I don't know what else to say.
Thank you, Nneka, for that. And Dr. Hardiman, please respond.
Sure. I think over the past couple of years, our communities have gotten to know and become more aware of the statistics that we are grappling with, primarily the fact that that Black birthing people are 3 to 4 times more likely to die as a result of being pregnant or giving birth or in the year postpartum. And, one of the statistics that we've known for a really long time, and that I think is an incredibly important marker of public health is that of infant mortality, where we've seen for, decades and probably centuries now that African-American infants are twice as likely as their white counterparts to die in the first year of life. And so I think we were grappling prior to COVID-19 with some incredibly serious and important issues that we're now seeing, exacerbated, and then within that, we are dealing with the fact that the social determinants of health, so where people live, work, play, worship, age, we know that those things matter for health, and that health, and particularly maternal mortality and infant mortality, don't occur in a vacuum, and that they're deeply embedded in these conditions, and that those conditions are shaping access to money, access to power, and certainly our, structural racism is at the root cause of that. And so, from prior to COVID-19, prior to a month ago, these were the concerns that we were grappling with, as a community, and the disparities that we've been, examining and thinking about ways to intervene on for quite a long time.
Thank you, Dr. Hardiman. And Ryan, please share with us your thoughts.
Compared with other racial or ethnic groups, American Indians have a lower life expectancy, lower quality of life, and are disproportionately affected by many chronic conditions. American Indians continue to die at higher rates than other Americans in many categories, including chronic liver disease and cirrhosis, the highest rates of type 2 diabetes in the world, heart disease, malignant cancer, unintentional injuries, assault and homicide, intentional self-harm and suicide, and chronic lower respiratory diseases. For my tribal nation, the Mandan, Hidatsa, and Arikara Nation, the life expectancy for men is 52 years, and for women, 54. The lower health status, lower life expectancy, and disproportionate disease burden of American Indians and Alaska Native people are a result of inadequate education, disproportionate poverty, discrimination in the delivery of health services, and cultural differences rooted in economic adversity and poor social conditions. The underfunding of our tribal health services and Indian Health Service, combined with the lack of providers, exacerbates the disparities through limited access to care. The Navajo Nation is currently experiencing an explosion of COVID-19 positive cases and more reported deaths per capita than New York and New Jersey. Not only is their healthcare system overburdened and under-resourced, but 40% lack running water, 10% have no electricity, 78% of their roads are not paved, 60% have no telephone, and 70% of their elders do not get regular routine medical care. And all of this is prior to the pandemic. Currently, the Navajo Nation has more than 2,300 coronavirus cases and 73 deaths.
Thank you, Brian, for sharing. And Dr. Charlotte Smith, please share with us.
Thank you. I think it's important that we, understand that these disparities have existed for centuries, and we can't just define them as appearing. That the reality of it is that doctors, other social support systems just do not listen to Black or brown women, neither do they value them in their health care. It's important that we start our conversation talking about racism, not just race itself, because racism is the driving force behind these high rates of maternal and infant deaths in the African American community. These systemic barriers are fueled by both explicit and implicit bias. And in order for us to address these issues, we have to first start with dealing with public policies, institutional practices, and cultural representation work to reinforce and reduce these racial inequalities. Black women experience multiple structural inequalities, such as access to health care, poverty, lack of education or underfunded education, environmental factors, lack of affordable and quality housing, nutrition, childcare, necessary social services, as well as this implicit and explicit bias, not just in the healthcare system, but in their communities. And when we talk about social determinants of health, we have to also talk about those social support networks, which are often lacking in our Black communities, especially when it comes to supporting Black women. There's this assumption in medical practice, particularly, that Black women are strong and they can adhere to a lot of different pains, and these things lead to and basically exacerbate these disparities. And so we have to start to think of Black women as individuals, as those that are valued in the community, and we have to listen to them because they understand their bodies and they know what they need to better themselves as well as their families.
Thank you, Dr. Smith. And Tamoria, please share with us your thoughts.
Hi, everybody. Well, I'm just going to piggyback right off of what Dr. Smith just said. She really hit a lot of the points that I thought were super important for me to make today. So, I'm just really focused on what leadership looks like. And it is really concerning to me when I look around and see the people that are leading the efforts in maternal mortality and morbidity, because they really don't look like us, right? It's just the truth. And so I think it's important to really start from the top. So all of a sudden COVID-19 happened, and all of a sudden it was what? A big news flash for everybody except for all of us, right? Who are living these issues every day, that, wow, there's inequities in health. Oh my God, we have to react. But they didn't really react. They did what they always do, and they're still doing it. They're just talking about it, discussion after discussion, right? And they never follow up with, what's the after part? What's the after part? Once you say that there's inequities and disparities in health, well, what is the action? Sure, they can stand on a stage and acknowledge it, but there's never, okay, this is what we're going to do to implement a solution. So when we look at the task force that currently exists in our country, let's start with the White House, right? So there's 22 members of the White House task force, including two women, and 20 men. So are women in general, are women's voices going to be really heard on a task force like this? Let's face it, probably not. And out of these 22 members, 18 are white. So let's do the math on that. How are the voices of Black and brown birthing people really going to be represented or heard? And we always have this sort of false assumption that if we see one brown or one Black, that, okay, that's enough. We know that's not enough in these situations. So we have Jerome Adams and Ben Carson being the only Blacks, and they're men. And we're talking about maternal mortality and morbidity. So we're looking at women dying at 3 to 4 times the rate of white women. And we have a task force with no Black women on it. No Black patient advocates, no Black female OBGYNs, no Black midwives or doulas of any race, right? No social workers and no mental health professionals. So you might have even heard just a couple of hours ago, they announced that the task force is going to disseminate by the end of May, right? They're going to just phase it out. So now that they've opened up the door about the fact that these inequities exist and put it on this public stage, what's going to happen to all the people they were just talking about, all the people that were affected by this and that are going to suffer now and will continue to suffer? So for me, this is just representative of everything I've seen in the last decade of being a maternal health advocate, right? Now, just for the people who are new to the call or new to knowing who I am, I'm a person with a lived experience. I suffered a postpartum hemorrhage in 2010 after the birth of my oldest daughter. So what I've seen on this task force mirrors everything I've seen with so many maternal health organizations. When you look at what happens in the leadership, there is absolutely intentional exclusion of Black women from participating. And there's really no excuse because we know that we have plenty of Blacks that work in healthcare at all levels, right? And we have patients that are willing to jump in and share their stories, like, you know, myself and NECA and thousands all over the country. So how can we truly begin to solve inequity and eliminate these disparities when we are not seeing equal representations of the populations affected across the board, but everyone's claiming to want to help these people? And I don't know if you guys have seen, even on Twitter a few weeks ago, I think it was even just last week, Vanderbilt University shared a tweet about a town hall they were hosting about surgery during COVID-19. The picture on the panel was what? Take a guess. All white men. So we're always going to be stuck right where we are because, and I know that, because we're going to be stuck where we are unless we see the leadership change, because nothing has changed in a decade of me doing this work, and nothing, just as Dr. Smith said and a couple other people laid out earlier, with decades of this. And how does that change? What is going to be the catalyst for change? It has to go from the talking about it and focusing on, yep, these are the groups that are suffering, to these are the groups that are suffering and this is what we're going to do about it. And part of the actual doing is, it's like, surprise, actually having Black and brown people doing the work. Giving up those seats that are held by other people and giving them to Black and brown people in an equitable way.
Thank you, Tamoria, for sharing very strong points. So we'll move on to our next question. COVID-19 escalated quickly in the U.S. and hotspots emerged where the local healthcare systems have been gripped by external and internal factors challenging their capacity to respond to this crisis on multiple fronts. We know that Black, brown, and tribal communities are unfortunately represented disproportionately in COVID-19 cases and deaths. Considering Black and Native women and birthing people are 3 to 4 times more likely to die of childbirth-related causes, regardless of socioeconomic status and educational attainment, what concerns you right now? What are the urgent needs? How has COVID-19 heightened the racial inequities we're seeing? What is being uncovered? And Dr. Hardiman, we'll start with you.
Thanks, Akisha. So I think there's a lot that concerns me, and I think there's a lot of urgent needs. The one that I'll bring up first is particularly salient given my role as a researcher, as a health services researcher, and that's that we need data. We don't have a lot of data. There's been, gross underreporting of tests of hospitalizations and deaths related to COVID-19, and how it's with respect to racial and ethnic communities at both the state and federal levels. And, to my knowledge, nearly half of all states have not included any data on race or ethnicity of those affected by COVID-19. And even the data that's being released by the CDC right now, it's a lot of it is incomplete in the sense that it doesn't share those race and ethnicity statistics for deaths or for anything else. You know, and I think that that's an incredibly concerning and incredibly important piece of this puzzle. You know, incomplete data allows for inaction. And so we need to know both, not just the deaths that, you know, that are happening disproportionately in these communities, but also we have to understand who's getting tested and who's getting access to tests, who's being turned away. And I think that's also critical for a public health approach and being able to really sort of launch a public health efforts that are community and culturally centered. We can't do that without the data. You know, I think, I'm sure there's a lot that folks have to say on sort of other parts of this, but I think generally what's being uncovered is not new to most people in Black and Indigenous communities, right? These are, you know, what's being uncovered is that people are suffering and have been suffering for decades and for centuries, and that there is a system in place that has oppressed communities of color for a very long time. So to me, it's not necessarily that that's, you know, what's new, it's that new people are paying attention, right? And new people are saying, oh, wait, you know, this is what's happening, and starting to realize and make those connections, particularly between sort of the health and the social piece, right? And understanding how social policy is health policy, and that, you know, in order to keep communities healthy, we have to be thinking about everything from paid sick leave to Medicaid. And access to care. I think it's also brought up issues related, at least to me, around you know, our reliance on a healthcare system that is here for profit in many ways, and how not sustainable that is in the long term, and particularly if our goal is health equity. I think it does open up a lot of space to me, which is really exciting, around innovation that is led with health equity. And so I think, and what I hope we have time to discuss today in the, you know, in the Q&A is, how do we do that, right? How do we think about the ways to fix these problems and to build new systems that in which we can lead with equity?
Thank you, Dr. Hardiman, for your response. Ryan, please share with us.
What concerns me is that people stay in contact with their provider over the course of their pregnancy and make their prenatal visits. Prior to the pandemic, expecting Native women already had many barriers to getting to their provider and prenatal visits, including discrimination, distrust, transportation issues around substance use, and isolation of reservation rural communities. So having this added mental health burden and the anxiety of having to decide whether to go into the clinic and possibly be exposed in addition to these other barriers concerns me. Urgent needs include consistent and constructive communication to our Native communities around COVID-19 and to birthing people, and adequate resources for underfunded and fragmented tribal healthcare. COVID-19 has spotlighted the racial inequities in Native communities in many ways, particularly in our tribal health systems that are being stretched to the breaking point under the growing number of coronavirus cases flooding into rural clinics and hospitals that are unprepared, under-resourced, and have chronic staff shortages. A century of neglect and underfunding of Native health systems is now showing its consequences. The federal government appropriated $8 billion for Native nations in the CARES Act, the largest amount ever appropriated by the federal government to tribal governments. But that money is delayed, and tribes have been asked to file a lot of paperwork and jump through bureaucratic hoops for this money, something that state governments do not have to do. Tribes have to write complicated applications to access this funding. States and governors do not have to do this added burden. As of Friday, none of the COVID funding had yet been accessed by any tribal nation. Additionally, testing for coronavirus in our tribal communities is inadequate. For example, only 1.4% of the Standing Rock Sioux tribe here in North Dakota have been tested for the virus.
Thank you, Ryan. Dr. Charlotte Smith, please share with us.
Thank you. There are a number of things that concern me during this time. I think there, you know, the fact that we don't have the data, no one's collecting the data. It seems like we're not concerned about the data and disparities. Quality of care, access, trust, tailored care, social support systems while giving birth are throughout prenatal care, mental health, prenatal visits, whether or not the telehealth creates additional biases and stereotypes because now you have access to more of my livelihood and my lifestyle. Doctors not receiving the bias training needed because of the COVID-19, and we're separated from that educational component. But I think my overall concern is that my fear is that this will become a COVID-19 effect, which to me means that once COVID-19 passes, because it's not our first pandemic, we had Ebola, we had SARS, we had H1N1, we had H1N2, there were disparities during that issue, and that this has created an awareness, but once we're past COVID-19, is there an assumption that the disparities have been addressed? That is my overall concern. I think that throughout COVID-19, we need to still remember, and even after that, these women, they deserve to be treated with dignity and respect throughout their prenatal care, throughout labor and delivery process. And they also, I think one of the things that COVID-19 has done is it has heightened that thing that we have been advocating for years, which means that women need to continue their Medicaid coverage 90 days postpartum so that they can receive the care needed.
Thank you, Dr. Smith. Tamoria, please share with us.
So one of my greatest concerns is the lack of access to mental health services. You know, I've really been trying to put myself in, you know, in this situation. Imagine myself giving birth and being a person who had no pre-existing conditions, but under these types of circumstances, I would certainly be feeling fearful and anxious. Now add on to that, you have a person have a postpartum hemorrhage, right? And then they have to go home. We're assuming that everyone has access to telehealth. The way that people talk about mental health is like, oh, okay, well, you know, if you get home and you're having certain things, access telehealth. You know, and it's like not everyone has both financial access, you know, or perhaps even the time. You know, there's people who actually have to, you know, give birth and they don't have, you know, this leave that they can take. They have to go right back to work. And we're not really considering what mental health looks like in terms of access. Also, along with mental health, I really stress that there's no, and this is to, I have a friend, Divya, who's an LCSW, and she always talks about integration. And so it stays in my brain, the word integration, because whenever we're discussing these issues, you rarely see a mental health care provider included. And I believe that the next phase of all this, the next surge, if you will be in mental health. It'll be a series of mental health crises on a few different fronts. One, just people being stuck in the house all the time, right? That's really tough for people. Now add on to that postpartum depression, a traumatic birth resulting in PTSD, or a woman dealing with postpartum psychosis. Even people who had no, you know, pre-existing, disorders. Some of them will come out with a disorder just based on the circumstances. And I feel that there's a lack of attention dedicated to including mental health care providers. And then along with that, making sure that people will have greater access to the type of mental health services that they need.
Thank you, Tamoria. We really appreciate that perspective. Nneka, please share with us what your concerns are right now.
My concerns are, as a doula, we've been fighting for our space in the hospitals. And now that COVID-19 has hit, we've been removed. And we're doing our best as doulas, providing distance support via FaceTime, via Zoom, via however we can do it while our clients are laboring. However, it's not adequate. It's not what our clients wanted. They're receiving, I'm being told that our clients are being left in rooms to labor by themselves. They're in the room in the bed for the duration of their laboring period, which is leading to additional anxiety, additional time laboring, and so on and so forth. Get the support back into the hospitals or into the birth setting or wherever it's needed at the time, because our birthing people need that support. In addition, I'm seeing that we need more traditional midwives. People are not comfortable going into the hospital. That's all fine and good. Let's let them give birth at home. Let them give birth at home safely with someone who is trained. There are so many people saying that they're not comfortable with going because they don't want to, they don't want to contract the illness. I supported a mom who wore her mask the entire labor and delivery. 33 hours of labor, and she had a mask on. How comfortable is that? She was on her back the entire 33 hours. And when things just didn't progress, the doctor said, okay, if you haven't delivered in 5 more hours, we're going to give you a C-section. I've heard that across the board as well. We need to wake up and do better by our people. We've shown the statistics that doulas do help in Black and brown birth. It changes the face, it changes the dynamics surrounding maternal and infant mortality. Now we're backsliding due to the COVID pandemic. It's a sad day. It's a real sad day.
Thank you, Nessa. We really appreciate you sharing the stories of others and what they're experiencing right now. We're going to move on to our next question. And Ryan, we'll start with you for the next question. What do you suspect the long-term impact of COVID-19 will be on pregnant people or birthing people in these communities? What will shift, or what attitudes and our social norms will change?
On my reservation, there is no hospital in which births can occur, so women in some cases must travel up to 150 miles one way to Bismarck, North Dakota to have their baby. When they get there, they are sometimes met with racial discrimination and prejudice. My concern is that COVID-19 will exacerbate this discrimination and prejudice due to ignorance and fear by the non-Native community and their perceptions of tribal communities and Native people in a time of pandemic. I also suspect that our Native women will become even more disinclined to stay in contact with their providers or go to clinics for their prenatal visits for fear of contracting COVID-19, and possibly as an excuse to mask the historical distrust our Native people already have with healthcare systems and some providers. Resources in our tribal communities are already an issue, and couple that with COVID-19, there are severe consequences. Take food, for instance. Our tribal communities and reservations are food deserts, and the costs of food are disproportionate compared to the national average. So couple that with the current nationwide food shortages and the fact that some businesses are now refusing to transport goods and supplies onto reservations for fear of contracting coronavirus. This creates a huge problem for the cost and security of food in our tribal communities.
Thank you, Ryan. Dr. Smith, please share.
Thank you. I suspect that we will go backwards. That's most of our work that we've done around maternal health, maternal and infant disparities will be diminished by COVID-19. And when I say that, I mean that maternal health will suffer as resources are diverted to combat the virus. The difficulty of tracking high-risk pregnancies will intensify as prenatal checkups become virtual, and the fear of contracting the virus deters women from seeking the in-clinic checkups and even hospital deliveries. And remember, as was mentioned earlier, that many of us have access to internet and many of us do not. So how are we seeking that care right now? How are we accessing that? I think that this issue could also be heightened, and there could be additional funding placed into different organizations to support research around addressing these disparities, but who will conduct this additional work and how will they address the disparities? Are we going to continue to do the same thing, which is insanity because we've been doing the same work for a number of years and expecting different results. So when are we going to change? I think that we're also threatening reproductive health at the same time. I think that the right to make the decisions about your bodies is being taken away, as many states have put restrictions around reproductive health rights, particularly abortions are being put in place in many states. I think that we can refer back to a study that was done during the Ebola epidemic where we saw a decrease in access to care and a 34% increase in maternal mortality for those given birth. While the healthcare system is certainly more advanced now, I just think that this pandemic will have a substantial impact on maternal health and infant health and overall family health as we have limited access to care or limited opportunities to follow up. Because remember, we're in a time of telehealth, which has some advantages, but some disadvantages is going to be who has access to telehealth and how do we follow up with those who are not seeking that health currently.
Thank you, Dr. Smith. And Tamoria, please share with us what your thoughts are.
You know, I'm really worried because I have a lot of patients from all over the country that contact me looking for both physical and mental health care providers. And when they contact me, especially when they're not in my geographical area, I get like this rush through my body in two ways. I feel grateful that they found me, but then I'm also profoundly saddened. The fact that someone literally in the middle of Louisiana reached out to me a couple years ago because her OB refused to see her, and I had to facilitate having her airlifted out of the hospital, right? These are the real stories, boots on the ground, of maternal health that you don't hear about. These are the real things that happen to Black people, being in a hospital and asking for your doctor, and you don't see that person for 4 days. There's no excuses for it. Right now, let's multiply that times millions of Black women. I keep hearing the same thing. People are afraid to go to the hospital. They know that when they go, they're experiencing their concerns being dismissed. They reach out to someone like me who says, you know, keep fighting, you know, let's try to find another person for you. But it's exhausting, let's face it. Even for myself, my OB was the third one in my first pregnancy. I switched 3 times because I wasn't being treated right. Not everyone has that luxury, and I realize that, which is why I push so hard for all these things to happen for patients, because it's just exhausting. You're being weathered by the day-to-day microaggressions and racism and implicit bias you face. You want to get care and then you're being treated like crap by your caregiver. So you feel like, I'm just going to give up. And all those decades of that, I truly believe it internalized itself and it's passed down from generation to generation. And what I would like to see for us, my biggest concern is that people of color have now got to come together. Black, brown, yellow, all of us. It's about empowering each other, really building community with each other where we see ourselves as leaders and create opportunities for each other to be leaders wherever we are. If we have a seat at a table, let's make sure that we get other voices that look like us at that table. Or even if they don't necessarily look like us, if we know there's a need in a certain community and that person's not there, and there's decisions being made about bodies that don't look like ours, bring them in. A lot of work in maternal health is done in silos. And let's face it, that's how it's always been. Let's keep them separated. Let's keep the information separated.
Thank you for sharing your thoughts. Nneka, please share with us what you think will shift, or what attitudes and our social norms will change, and what the long-term impact might possibly be.
I agree with Tamoria and with Dr. Smith. So what I will say is what I hope to see. I'm hoping we can shift our paradigm a bit and do things the way that they used to be done. My grandmother is number 5 of 13, all born at home, a small 2-bedroom house. Let's go back to that for a little while. train more Black and brown people to care for our own, just until we can get to the other side of this epidemic. I'm not talking about COVID-19. I'm talking about racism from the 1800s or earlier to present. That's the only way that we can truly change this paradigm. There's no other way. We need to care for each other. We need more people. I mean, I only work with 2 doctors and 1 midwife as a doula. And that's because I know that my clients will be safe, that their babies will be born alive and healthy, because these doctors and this midwife care. If you know, I mean, I've been saying for years to my counterparts, just find someone in your network that you trust. You've seen them work firsthand, and then partner with them. It's these partnerships that will bring about a change. And stop giving this money to the people who do not have our best interests at heart. That's what we need to do. We need to shut down all of these places that get the money to support us. And we need to support each other. Everyone on this panel needs to support each other. And everyone who is here listening needs to support everyone on this panel and beyond, so that we can support you. That's the only way we're going to see a change.
Thank you, Nneka, for sharing. And Dr. Hardiman, please share with us.
Sure. So, you know, when I think about the long-term impact of COVID-19 on pregnant and birthing people, I think Ryan brought up the historical distrust piece, and I think that we're going to continue to see that. I mean, that's deeply seated, and it's, you know, very much a part of our history and has been for a very long time. And I think we are going to continue to see that, and it's going to be heightened, you know, as we deploy an important public health method of, you know, contact tracing, right? And you know, working to really understand and help contain, you know, exposure. It's important to do contact tracing, but I think it's also important to think about how to do that in a way that is culturally appropriate and feels culturally safe to communities who have historically been harmed and marginalized by our healthcare and our public health systems. I also think, you know, related to the long-term impact of this, you know, my colleague, Rebecca Polston, who's the owner and founder of Roots Community Birth Center here in the Twin Cities, called me the other day, and she said, you know, my families are in crisis. You know, these are families that have opted to birth at one of the nation's only Black-owned birth centers and have been thriving in that space. And within, you know, a 4-week period, that's shifted, which I think speaks very much to the precarity of Black livelihood and Indigenous livelihood in our, you know, in our communities. And this, you know, this incident has pushed folks who were already on the margins even further out. And we're going to continue to see that play out among those birthing in our communities and the families that are supporting them, from a financial perspective, an employment perspective, from you know, food insecurity and all of those other determinants that we know are dictated by social and structural inequity and structural racism.
Thank you so much, Dr. Hardiman, for sharing that with us. And our last question this evening is, and Dr. Smith, we're going to start with you. From your perspective, what is your unique role in addressing the pandemic? What is the path forward?
So I think as a health services and health systems researcher, that my main role is really determining how to create equitable healthcare systems, not just for patients, but for providers as well, those that are providing healthcare on all levels. Producing scholarly work to create awareness around these disparities, influencing policy and engaging the right stakeholders, so making sure everyone's at the table. Making sure Black and Brown women voices are heard and valued. My path forward is really addressing chronic stress and making sure that we improve the education awareness of these implicit and explicit biases. But I think overall, moving forward, I have to take the stand of I will not give up. I will not give up or be silenced until we're able to save every Black woman, until we're able to prevent these avoidable deaths among Black women and their infants.
Thank you. Tamoria, please share with us.
Man, you asked what my unique role was. Did you really have to ask that? I mean, a simple Google search for everyone, I think. All right. So I'm sitting here thinking about my unique role. I'm unique in the fact that I lived through what I lived through, and that I gave up a career that I loved because I was passionate about making sure that people get treated in the way that they deserve, you know. And it's important to me to make sure that wherever I am, no matter what the consequences may be, that the voice of the patient is heard. It's never a popular position to be in. It's one that I feel is absolutely necessary, following in the footsteps of my ancestors who went through so much worse. How hard is it really to stand up for yourself? I'm not being chased by dogs. I'm not being sprayed by hoses, but I'm watching people who look like me, mothers who have to die, and children and families who have to live with the trauma for generations of losing a mother and their home, when most of these deaths could be prevented. It is not hard to stand up and speak for and represent those people and all Black and brown people, considering that if we want to truly move forward, we have no other option. We have to stop being afraid. I feel that fear has been instilled in us since we came to this country to stand up, to speak up, and also to support each other. And I would like to see us all get to a place where we see each other, hear each other, and take that and put it into action by standing up for and demanding better for each other.
Thank you. I really appreciate that. Nneka, please share with us.
Wow, that's a hard one. I guess I would say my role during this pandemic is pretty much the same that I've been doing for almost 10 years, and that's providing support to families who suffer the loss of an infant from conception through age 2. That hasn't changed any during the pandemic. I'm still doing my work more virtual now, still finding resources for families, feeding families who have been displaced because of the pandemic, occupying the minds by allowing different members of my organization to use their hands to crochet something, whether it's to give to a family who's recently had a baby or lost a baby, or a throw for a senior while they're actively crocheting to make something pretty. They're not thinking about what's going on outside of their immediate surroundings. And trying to find answers, trying to figure out what we can all do to come out of this as one. You know, if we would all work together for just a year, I guarantee that we'd see a change, a positive change in Black maternal and Black infant mortality. Thank you for asking.
Thank you, Nneka. Dr. Hardiman, please share.
Sure. So I think we're watching a system that was never necessarily built to ensure that Black and Indigenous moms thrive and Black and Indigenous babies thrive. We're watching it collapse. And I think we have a really important and unique opportunity right now to build what will allow us to thrive. And so I see my role in that as creating and contributing to the evidence base, to the empirical evidence base as a researcher, to do just that, to build something and to pull from the history and the knowledge of our, our midwives and all of these incredible, people in our communities that have been doing this work on the margins for so long, and helping to create that evidence base to build what will allow us to thrive in our communities.
Thank you. And lastly, Brian, please share with us what you see as your role and what the path forward is.
At the American Indian Public Health Resource Center, we're working closely with the North Dakota Indian Affairs Commission, and I've assisted in drafting COVID-19 policies and protocols for our tribal nations, including a tribal response plan, as well as burial and mourning protocols for tribal communities. We're also in the midst of conducting a COVID-19 assessment of tribal leaders to determine the needs of our tribal communities here in North Dakota as they confront the coronavirus pandemic. Our center is assisting with contact tracing efforts with tribal communities across North Dakota. And we are also working to encourage Indigenous people to seek further careers in public health. NDSU has an MPH program that focuses on infectious disease, and the classes can be taken online. So we're encouraging people, our Indigenous people, to look at that. And moving forward, COVID-19 has completely upended the way we work and a lot of what we previously focused on, with the need for more immediate attention to truthful and adequate communication in and to our tribal communities, more emphasis on testing for our Native people, of course, adequate resources, and helping to find community solutions to best deal with the unique issues our tribal nations face today.
Thank you, Ryan, and thank you all for your responses. Now I'm turning over to my colleague, Lauren, to moderate the next portion of the program, the questions and answers. So Lauren, I'm going to turn it over to you.
Great. So I encourage you, if y'all have questions, to please send them in the Q&A box or the chat box, and we'll try to answer them. I am mindful that we're going to end by 7, so please get those questions in. But first, I'd like to thank you all for your time and just the insight that you provide to this health topic. And I think, as Dr. Hardiman mentioned a few minutes ago, that we're seeing the result of a system that was built that was not designed for us to thrive and survive in. And so with that in mind, I'm recognizing that there may be Black, Brown, Native birthing people watching now. What advice or insight or encouragement would you give them, folks who are pregnant right now, to have healthy pregnancies, to have pregnancies that don't feel fearful, to advocate for themselves? What advice would you give them? Can I go? Hi. I would encourage people to not internalize everything that they read, and actually to limit the amount of social media and all these articles about maternal mortality that they're digesting as a pregnant person, and try as best they can to find positive support groups, reach out to members of their community, such as doulas, a forest support system, and just get into a mindset that it is possible to have a healthy pregnancy, and your actual skin color is not a risk factor for you. Because we've been conditioned to think that just by simply being Black, that is an actual risk factor, and we know that's not true. It's encountering racism and bias that, exacerbates that risk. So I think it's important to just educate the public better about what risk really means in terms of maternal health, and help encourage women to realize that they can have a healthy pregnancy. Yeah. Great, thank you for answering that. Would anyone else like to answer as well before we move on to the next question? Great.
Well, we have a question that just came in the chat box, specifically for NECA. And this participant essentially described her experience as being a doula in New York City, and she's a white doula who works with lots of women and birthing people of color. And specifically asking, are there ways that white doulas can support birthing people of color well right now? And secondly, that a lot of doulas are having mixed feelings about not being able to be in the hospital, and are there ways that they can support birthing people as they're giving birth?
Well, one thing that I always tell someone who asks me that question, I always tell them to reach out to a doula from that demographic, from that ethnicity, and partner with them throughout the pregnancy to learn from them, or I often recommend, if someone who is not Black comes to me, I recommend them to someone who might be a better fit for them. If you do decide to take on that client, definitely try to partner with someone, because certain triggers might arise and you might not be aware of those triggers or what you're looking at. So, and secondly, it was hard to support someone virtually. However, we do what we have to do for our clients. So for me, when I supported a person who was having her rainbow a couple of weeks ago, I was there via FaceTime quite a bit. As I took cues from my client. When she needed me, I was right there. She'd text me, okay, I need to FaceTime with you now. Or sometimes she just needed me to answer a question. When she was concerned about the C-section comment, I emailed and FaceTime and inboxed her OB, who got back to us right away and called the hospital. So you just have to make sure your connections are made. The only difference is you're not physically there. You're a doula, you're trained, you do the same things, just not physically. You can teach the partner to do those roles for you if they're allowed in the birth room. I hope that answers the questions. I'm sorry.
No, that's fantastic. Thank you. So we have one last question, and then we'll go ahead and wrap up. But from another doula or birth worker in New York, essentially is also asking about their experience providing care for patients there. And this doula describes that there's a lot of, there's a tension among doulas because some folks really want to be in the hospitals and other folks feel conflicted and don't want to be in the hospital and provide care for patients. So I'm wondering if you all could speak to just concerns among birth workers for their own safety and wanting to provide care for patients, but also feeling tension about being in a hospital space as well.
I recently spoke to a doula who is still working, but she's only doing home births, which she's keeping herself isolated so that she will not contract the virus. But she says that she still doesn't know if anyone, each time she goes into a home setting, whether or not the person has the illness. I think instead of closing down the birth centers, what they should have done was transferred the option to give birth from the hospital labor and delivery unit to the, oh, my 5-year-old just came in, to the birth center.
A bug in the bathroom.
Okay, baby. But thank you. I hope that answers.
I would just add, you know, I think, you know, myself and some of my colleagues and many other researchers have documented sort of the empirical evidence around how doulas, the potential for doulas to improve outcomes, particularly for birthing people from low-income communities and communities of color. And, you know, where I see the disconnect is, so we know we have this evidence, so we know that having a doula is important and can improve outcomes, but we don't always, and depending on sort of the hospital system or the community that doulas are operating within, consider them to be a member of the healthcare team, right? So there's this disconnect where I think if doulas were viewed more readily as part of sort of the birthing team in that way, there would have been less sort of contention around their involvement, right? And, you know, and whether or not they were considered essential or not. And I think it speaks to some conversations that we need to have within the birthing world and the birthing space around like what, you know, what that should look like and what that means moving forward.
That's really great insight. Thank you, Dr. Hardiman. So with that, we're going to go ahead and wrap up. I want to thank our panelists for joining us today. We appreciate the time that you're giving, knowing that you're serving many birthing people and folks in the community these days. And then also our participants for your participation and willingness to join us today. This presentation and this webinar is being recorded, and we'll send a link out to folks afterwards. But just thank you all again for sharing about your experiences working with these communities, as well as the long-term implications that COVID-19 is having in a way that is exacerbating existing issues and concerns among our communities. We hope that the information that was presented and shared today will be useful in the work that you all are doing and planning, and we look forward to folks joining us tomorrow as we continue this conversation around COVID-19 delivery of care for folks in these communities. So in a few moments, I'm going to put the link to that webinar below, and we hope you're able to join us. And so with that, we thank you again, and we hope that you have a safe and wonderful evening, and goodbye.